it's not specific, but it is indeed a combination of symptoms, which I will go into because there may be an interest for some of you to validate in the Chinese and culture of Taiwan a checklist that's been designed to measure this particular component of the symptoms. Then there is the more classic mild cognitive impairment, which is usually 3 to 5 year duration before dementia. It is usually amnestic when it's Alzheimer, but it could be also language, executive, visual, spatial. But most persons over age 65 who will evolve to dementia of the Alzheimer type, this MCI phase is amnestic. Decliners, and then you look at perhaps their pattern of progression. They may have concomitant diseases such as a small stroke, other systemic illnesses, social isolation. So rapid decliners in the mild stage should be re-examined. They may also have another kind of dementia that was not apparent at first, such as PSP. So moderate stage dementia usually means you cannot live alone, or you need close supervision by frequent visits by family members. And this is the onset of the more difficult phase of behavior changes. Then severe, depending where you live in the world, you are usually not at home, or you're at home with a lot of help from family, neighbors, state-sponsored support. And then the last stage, as we discussed, which is more motoric with aspiration pneumonia as final cause of death. So I will now spend just 2 or 3 minutes on the measurement of these various symptoms, and I will emphasize MBIC, minimal behavioral impairment
Hello, Professor Gauthier. Can you hear me?
Yes.
Hi. Nice to meet you. Hey,
Thank
I'm
you.
Dr. Hu. Thank you.
Ah,
Thank
there
you
you are.
for giving
Yes.
us such good presentation and lecture. Thank you.
And there's a handout
Yeah.
that you can share. I prepared you a short handout with references.
Mm-hmm. Thank you.
What is the weather where you are now?
A little cold, but it's okay. No snow, no, but not very cold. How about in Canada?
It's been a strange winter. It was -40 last weekend,
Wow.
and yesterday it was +2.
Okay.
So instead of
Yeah.
snow, we had rain.
Mm,
So it's up and down. It's very bizarre.
yes. Yeah. In
We have about
Taiwan,
1 meter. We have about 1 meter of snow on the ground right now,
okay. Yeah.
but that's it. It's going to melt now.
Mhm. In Taipei, the temperature is about 20.
Plus 20.
Yeah, plus 20.
Wow. Oh, it's very warm.
Yes.
Super. You had your New Year
Yeah.
celebration?
Yeah. We have a very long lunar New Year vacation.
Yeah, it's the year of the rabbit. Yes.
Yeah, it is 10 days. So
Yes.
we are in hard time, just from the vacation. A lot of work have to do.
It's a big holiday in Asia in general, and I think a lot of traveling and meeting families, and
Yes. Yes.
it's the same in mainland China, and probably
Yeah.
Singapore and Singapore as well.
Yes, I think so. And Hong Kong and
Hong Kong,
maybe
yes.
Thailand.
Yeah.
Thailand also have the Lunar New Year.
You still make oolong tea?
Yeah, oolong tea in Taiwan is very popular.
That's the souvenir. One of the souvenirs I have from my visit to the southernmost city. It's Kaohsiung.
Taichung or Kaohsiung. Taichung is the middle Taiwan, in the middle Taiwan, and the Kaohsiung in the southern Taiwan.
My host took me to a oolong tasting ceremony, and I had 5 different types of oolong teas.
Oh,
And
yeah.
they made sure I made home. I went home with 5 years supply.
Okay. So you like oolong tea?
Yes.
Very
It's
good.
hard to find here, but there are tea houses where you can get exotic teas, but it's not the same as being where they are harvested or made. Yeah.
Okay. Yeah.
I want to thank the young man who made the recording. We had some technical issues, but it worked out.
Yeah. It's Dr. Huang Likai. He is a young faculty of our department.
Yeah.
His research will focus on dementia. Maybe he can learn from you. Go to the Canada. I heard you just undertook the cataract operation.
Yep. It's been 1 month. So it's strange because I don't need glasses anymore to look far, to play cards, watch TV, watch the screen, but to read, I need a temporary cheap glasses, and I have to wait another 3 weeks to get permanent ones. Just
Okay.
reading glasses. but it's very strange in someone who had myopia. It's been corrected now.
Okay. Wow.
They put special lenses that are designed to correct for astigmatism and myopia.
Mm.
And both eyes at the same time, so you're done.
Wow, it sounds wonderful. Okay.
Yeah.
One operation for two benefits.
Yeah. So when you ask, you find your neighbors, oh, we had it done before, and then it seems like it's a part of aging when you're in your 70s to get cataract surgery.
Yeah. You know, in Taiwan, there are so many people have a cataract operation. So when we check the light reflex, yeah, do our neurological examination, light reflex usually are unreliable. Yeah.
I don't know if you're one of the clinicians who answered the surveys for the World Alzheimer Reports, but Taiwan was the country who contributed the most per number of inhabitants. I mentioned that in my presentation. Taiwan, considering its size, was a remarkable contributor from the clinician survey perspective, the family care perspective. So thank you very much. Actually, it causes a bit of a bias because you do such a good job with caring for dementia that it looked like the world does a great job, which is not the case. So we have to take into account non-responder countries, and the other big country that contributed data was US.
Okay.
And it's very different healthcare system. Yeah. May I ask, do you have what you call Medicare, so everybody can access healthcare if they need it for free up to a point, or it's you have insurance while you're working and Medicare when you're over 65?
Yeah, we have a national health insurance system. Okay. Yeah, so I think most of the drug for Alzheimer's disease are covered by the insurance. Yeah, also including the diagnosis such as MRI and the blood test.
Okay, super. I guess we're about to start.
Yeah, 1 minute.
I was very honored by your invitation, and it was a pleasure to prepare this talk. And I'm giving later today a public lecture to the Retiree Association of my university, which is partly based on the material I prepared for you.
Thank you. Thank you so much.
So,
okay, let's start. Good afternoon in Taiwan and good night in Canada. I am Dr. Chaur-Jong Hu, the Director of Dementia Center, Shuang Hospital, Taipei Medical University. The Dementia Center commits to promote dementia care and update the dementia knowledge for physicians and the dementia care team members. We had 11 dementia masters in contributing this continuous education program in terms of a frontier in dementia research master lecture this year. In this year, we have a great sponsor from Azzai company, and we will continue to invite at least 11 masters to share their experience with us. The master today is Professor Serge Gauthier from the Alzheimer's disease and related disorder research unit of the McGill Center for Study in Aging, McGill University, Canada. He also is the professor in Department of Neurology and Neurosurgery, Psychiatry and Medicine at McGill. Professor Gauthier contributes to the consensus for management of dementia in different stages and the ethics of research involving person with dementia and the primary prevention strategy against cognitive decline and dementia. He has published over 700 papers, including ADI's World Alzheimer Report on the diagnosis of dementia in 2021. The title of his talk today is Research and Clinical Development in Dementia in Alzheimer's Disease. Let's welcome Professor Gauthier. We can start the video.
I don't know if you can. Good day to all of you. It's a pleasure to join you from Montreal, where it's today warm. It's only -12 centigrade. The topic I have to present was discussed with the organizers and involves research and clinical developments in Alzheimer's disease. Just some brief statement about conflict of interest. I'm a member of editorial boards and I give scientific advice to various companies. So the objectives for today's presentation are to give a perspective on the natural history of Alzheimer's disease with emphasis on stages even before dementia, look at recent findings in biologic research, summarize risk and protective factors for dementia, some of them amenable to population-based therapeutic approaches, and finally study examples of clinical practice guidelines developed by and for clinicians that may be applicable to your country. So 4 parts, and I have a brief summary at the end of each part, and then we'll have the question and answer period. So natural history of Alzheimer's disease, findings in Alzheimer's disease biologic research, population-based prevention, and development of clinical practice guidelines. So all clinicians in the audience will be familiar with the usual pattern of progression of symptoms in the course of Alzheimer's disease. We were trained many years ago to think of Alzheimer's disease starting at the dementia stage, but now we have actually earlier stages that are clinically relevant. Usually, most patients go through a phase that is less specific, but it's changes in mood and personality. Then there is cognitive decline, and then interference with daily life, that's dementia. And then, at least for Alzheimer's disease, a second phase of behavioral symptoms that is very troublesome, such as not recognizing their family members, not recognizing their house. And these behaviors improve over time. And then after 5 to 8 years, since onset of dementia, there is a Parkinson-like last stage with muscle rigidity, falls, and difficulty swallowing, leading to aspiration pneumonia. Now we will look at the different stages and start discussing how do we measure symptoms at each stage. This has clinical relevance for the audience and also clinical research relevance. So the new concept of mild behavioral impairment stage has been defined a few years ago. It's not specific, but it is indeed a combination of symptoms, which I will go into because there may be an interest for some of you to validate in the Chinese and culture of Taiwan a checklist that's been designed to measure this particular component of the symptoms. Then there is the more classic mild cognitive impairment, which is usually 3 to 5 year duration before dementia. It is usually amnestic when it's Alzheimer, but it could be also language, executive, visual, spatial. But most persons over age 65 who will evolve to dementia of the Alzheimer type, this MCI phase is amnestic. Then there is the more classic mild dementia stage, where people need a bit of assistance for instrumental activities of daily living, such as paying bills on time, taking pills on time, planning an outing. Moderate stage. So mild to moderate is usually 3 to 5 year duration, whatever you do. It could be shorter in some people, so we call them rapid decliners. And then you look at perhaps their pattern of progression. They may have concomitant diseases such as a small stroke, other systemic illnesses, social isolation. So rapid decliners in the mild stage should be re-examined. They may also have another kind of dementia that was not apparent at first, such as PSP. So moderate stage dementia usually means you cannot live alone, or you need close supervision by frequent visits by family members. And this is the onset of the more difficult phase of behavior changes. Then severe, depending where you live in the world, you are usually not at home, or you're at home with a lot of help from family, neighbors, state-sponsored support. And then the last stage, as we discussed, which is more motoric, with aspiration pneumonia as final cause of death. So I will now spend just 2 or 3 minutes on the measurement of these various symptoms, and I will emphasize MBIC, Minimal Behavioral Impairment Checklist, because it is new, and there is already a validated translation from Hong Kong, which you may or may not find useful in Taiwan. And I want to spend just a minute on CDR, Clinical Dementia Rating, and Clinical Dementia Rating sum of boxes, because it's now used in clinical trials to show the efficacy of the new generation of drugs aiming at lowering brain amyloid levels. And as clinicians, you want to know, is that useful? Can we use this clinically? And what we find in clinical trials is meaningful. So MBI, Minimal Behavioral Impairment Checklist, essentially it's a list of questions that I will show in a second that is destined to be filled by oneself. Remember, this is before dementia checklist. Can be filled by an informant or an observer. And essentially, it's to find changes in behavior, personality that emerge, the new symptoms, over age 50, and persisting for at least 6 months. So the 5 domains are listed here. So you recognize apathy, mood, anxiety, agitation, mild agitation, just being cranky, social inappropriateness, and perhaps early psychosis. So this is what the checklist looks like. Of course, we cannot read it on the screen, but I encourage you to look up the website, mbitest.org, and look at the Mandarin, Cantonese, perhaps Cantonese translation available out of Hong Kong, and you may want to see if it's useful for your needs. If you do decide to have a Taiwan Chinese variation of the MBIC, do send it to the lead author, Dr. Zainur Ismail, and he will put it, your validated translation, on the website, so it's available around the world. It's the same for the MOCA. It's now available around the world in multiple languages. So the CDR was developed over 20 years ago to help measure changes at the MCI stage. John Morris was the lead, and it's a semi-structured questionnaire which takes about 20 minutes to do. It's done initially with the accompanying person and then with a person with symptoms. 6 domains, 3 cognitive, 3 functional. So memory, orientation, judgment, and problem solving, that's 3 domains. Community affairs, home and hobbies, personal care, that's 3 domains. Each domain is scored 0 to 3. So the maximum score for impairment would be 3 times 6, 18. That's the sum of boxes. Okay, to give you a feel for what it corresponds to clinically, 4.5 thereabout is usually found in mild dementia. The progression over a year is in the order of 0.5 to 1.4. Now, the best results found so far with the anti-amyloid therapy using lecanemab is 0.45, which is a bit less than 1 year. So this is what the curve looks like in the publication in the New England Journal of Medicine that came out recently. And after 18 months of IV treatment, twice a month, you see the decline on placebo in blue, steady increase in score of the CDR sum of boxes. And there's a lower, less decline on lecanemab, but the delta is only 0.45. So Is it sufficient for the cost and the trouble of twice monthly IV infusions with the risk of brain swelling and hemorrhages area? That is for each country and clinician and patient and family to decide. So to summarize this first part, which is natural history of Alzheimer's disease and trying to measure some of the symptoms even before dementia. There is a typical pattern of symptoms of progression in AD. What would be atypical and may lead to a differential diagnosis would be early onset of hallucinations in DLB, early onset of gait impairment in hydrocephalus or multiple small strokes, mixed dementia. The intensity of the different types of symptoms do change over the stages. And for instance, in moderate to severe dementia, you would use not the MMSE, but perhaps a severe impairment battery. For behavior, you would use the neuropsychiatric inventory in moderate to severe dementia, not the MBIC. And finally, there is variation in the speed of progression in terms of natural history, especially in the mild stage, where it varies between 3 to 5 years. It could be as short as 1 to 2 years, in which case we call them rapid decliners. And some people are stable for 5 years, whatever you do, and then you wonder, do they actually have mild dementia of the Alzheimer kind, or what is happening? But then they start declining at year 5. So findings in Alzheimer's disease biologic research. The big excitement was the biologic definition of Alzheimer's disease, which would allow you theoretically to say someone has Alzheimer's before they have any symptoms. And there's a debate about whether this is appropriate. Nevertheless, it has a big impact on research, and it would be very difficult for you to publish now a research on mild cognitive impairment without ATN characterization of your population. So A for amyloid, T for tau, N for neurodegeneration. Honestly, the easiest way to get the measurement is spinal fluid, because you get in the spinal fluid amyloid low levels, and you can do ratios 40-40. You also get tau total, which is equivalent to neurodegeneration, and phosphotau, which is specific to Alzheimer's disease. So if you ask me what would be the cheapest way to get this ATN characterization for an individual patient or groups of patients, it would be this spinal fluid. But very soon there'll be blood equivalents, and I'll get onto that in a second. And finally, for research, we use PET imaging, and I'll show you some spectacular pictures that will not be used in the clinical routine, but nevertheless, it may help in, let's say, proof of concept. When you have a new therapeutic approach, you want to show if it really changes the brain chemistry, even if it's targeting only inflammation or amyloid or tau. So this is an example of a use of PET imaging in a research cohort at McGill University, where I work. These are volunteers who have a lumbar puncture every year, PET scans for amyloid, that's the top line, for tau, that's the middle line, and glucose scan, FDG, the lowest line, as an index of neurodegeneration. And the point being made here is that each person has his or her pattern of changes. Some have more amyloid, some have a lot more tau, some have neurodegeneration. They don't all correlate perfectly, but as a group, they do. In other words, you will rarely see someone with a lot of tau if there's no amyloid, but it happens, as I will indicate in a second. Most people with amyloid and tau and even mild symptoms have some evidence of neurodegeneration on the glucose scan. Just want to show in the circle the scans how sensitive, how the spatial resolution of the new ligands for tau, how accurate they are. So the one on the left is someone with no symptoms, and he or she already has a tau buildup in the entorhinal cortex and hippocampus region. So that's a BRAC2 on the scale of 6. The one on the right is someone with mild cognitive impairment, no dementia, but you see there's more tau in that person starting to spread into the temporal lobe. And if you have enough people in your cohort, you can have this in vivo mapping. These are all different people having stage 0, no tau, and 1, 2, 3, 4, 5, 6, which is equivalent to an autopsy. So the power of spatial resolution with the tau imaging is totally spectacular. And my hope is that the new treatments for Alzheimer will show a delay in progression from stage 2 to 3, which would be roughly MCI, stage 4 to 5, which would be roughly mild to moderate dementia. Surprise, in someone here who's age 80, he looks like he has Alzheimer, classic. He has no amyloid in his brain. It happens. 5 to 10% of people, we say that's a classic person with Alzheimer. There's no amyloid in their brain. So either we don't see it with the amyloid scan in use, the particular ligand, it maybe is not seeing the oligomers so well. The ligands tend to tag on the plaques. But this person also has no change in the amyloid in his spinal fluid. So it's a tau specific dementia, and we're not sure what to call it yet. So we call it for now tau predominant dementia. And over time, this person may actually have progressive supranuclear palsy or cortical basal degeneration. It may be an atypical presentation for a non-Alzheimer dementia. So blood. Indeed, there's been a lot of progress in the past year or two. The phospho-tau that we can measure in spinal fluid, it does leak into the blood, and fragments, so-called isoforms, tend to be normal in the blood at the same time as the PET scan is changing from BRAC2 to 3 to 4. Wow. So we could have a blood test such as illustrated on the left in the red box. The blue box in the red box is high levels of p-tau 217. There's a debate about which particular isoform is more useful for early diagnosis in someone with mild symptoms. And perhaps another isoform will be a good indicator of response to amyloid therapy. It's starting to show in clinical trials that if you lower amyloid brain levels a lot over a year or two, the p-tau in the blood also will change. It will be lower because there's a downstream effect. If you help amyloid, you also help tau. That's the way it looks. And on the right, you see the more recent version of the famous curves, what happens over time. Dr. Clifford Jack started this illustration of what happens in terms of biomarkers before dementia. So you can see the latest version where changes in fluids, so spinal fluid and blood, do precede detectable change in the brain imaging using PET. So as clinicians, we will be using spinal fluid, as I hinted at right from the start, and perhaps blood as a screening for who needs a spinal tap. Bon, a few words on the pathophysiology of Alzheimer's disease. This is the classic here sequence that we learned in medical school. Beta amyloid deposition would come first over at least 20 years before symptoms. In the middle, you have the neurofibrillary tangles. It's within neurons. What's new is that the neurofibrillary tangles do leak out of the synapses and spread to other neurons. In the left, you have microglial activation. This is important because it may be amenable to therapy if we can detect inflammation, neuroinflammation at the right stage of disease, and it may be before you have MCI, so very early. So good news is we have new ligands that are starting to image on using PET, neuroinflammation, and hopefully we'll have spinal fluid and blood equivalents, although that's proving difficult because you can have systemic inflammation, arthritis, many factors at play in systemic inflammation, but we're working on that. Because if you could stop the microglial activation at the early stage of before you lose a lot of synapses and you have neurodegeneration and symptoms, you could possibly delay progression. And the best evidence for that is epidemiologic. So people with chronic arthritis are known to have a much reduced risk of dementia. That's old knowledge from 30, 40 years ago. And it's probably because they use NSAIDs, non-steroidal anti-inflammatory drugs, chronically, but we don't know which one is best, what's the minimum dose, and the minimum period of treatment. Probably it's in the order of 2 years. Probably the old NSAIDs, indomethacin, would be the best. We don't know which dose is required to really suppress neuroinflammation. So expect another wave of interest in neuroinflammation in the next few years, and hopefully safer drugs than indomethacin will be tested. So this is a diagram made by my work partner, Dr. Rosa Neto, and he tried to list the various factors at play in dementia of the Alzheimer type. And the point being made here is it's more than amyloid and tau. You need a third or fourth factor to get symptoms. The best evidence for that is that over age 90, post-mortem studies have clearly showed that a lot of people with no symptoms, have a lot of amyloid and tau in their brain. So what's protecting them? So the reason may be they don't have small strokes, they have resilience, biologically speaking, maybe they have resilience from their lifestyle. I'll come back to that later. So on the left, unhealthy lifestyles, impaired cerebrovascular function, that's been established that if you prevent strokes, you do reduce the number of people with dementia. That's been shown in parts of the UK and Scandinavia and one province in Canada, Ontario. So an aggressive campaign against stroke will lower the number of people with dementia. Inflammatory response, I already mentioned, genetics and comorbidity. So the point being made here is that if you have 3 or 4 of these factors, they're not just additive, they are synergistic. And we cannot change perhaps amyloid deposition with time as we get older, but we could change the vascular risk factors, prevent small strokes. We can control inflammation if we can catch it at the right stage of disease. And if we have comorbidity like impaired hearing, impaired vision, maybe we can work on that. So back to the more classic reason for treating as early as possible in Alzheimer's disease is that this middle phase, mild cognitive impairment, a lot of pathology is underway. You've seen the curves. It's where most changes are taking place in terms of biomarkers. And now there's interest in the pre-MCI, maybe called subjective cognitive decline or impairment phase, or no symptoms, but you're amyloid and tau positive. So that may be a new kind of person to treat preventively. Most of the treatments have been in the past 12 years at immunotherapy for amyloid, but other treatments have been tried, such as gamma secretase inhibitors, fibrinogenesis modulators, prevention of aggregation of amyloid fibrils. These are oral agents. They didn't work. So immunotherapy is the mainstay. In terms of clinical trial, what we were hoping for way back 30 years ago is the D line. Once you start treatment in mild dementia, you are stable, no progression, as long as you treat. This is not what we find. So this is the best results available for now, lecanemab in the New England Journal, as I mentioned earlier. I already showed you the top that graph. It's the primary outcome, CDR sum of boxes, with the difference of 0.45, which is equivalent to a bit less than a year of progression. And I just want to contrast that to the middle left that graph, which is the amyloid normalization. So there's no issue that immunotherapy with medications such as lecanemab, aducanumab, do lower brain amyloid content. There's no issue with that. The issue is that it does not correlate with a big stabilization of symptom progression. So is it too late in the course of disease? These are MCI or mild dementia person, or is it, we need to combine this treatment with something else. So the next wave of trials will be combination therapies. It could be done in sequence. So people who've had their normalization of amyloid after a year and a half, they're randomized, for instance, to just follow-up with monitoring using blood markers, or now they're randomized to an anti-tau agent, oral preferably, or IV, using antibodies against neurofibrillary tangles, or an anti-inflammatory drug if the person has active neuroinflammation. So expect a new wave of clinical trials that will be a sequence of treatments. A bit like chemotherapy, where you had your first phase of treatment, you're in remission, then you can be randomized to some other treatment. So to summarize this section, the new biologic definition of AD is important for research. If you do cohorts studies, you may be asked by the participants, what's my amyloid and tau status? So you have to be ready to disclose the results as risk factors, not you have Alzheimer's disease because you're 50-year-old and you have amyloid and tau in your brain. That most people would disagree with that. What about other factors? So vascular is important, neuroinflammation, alpha-synuclein, the DLB component of many patients with dementia, and TDP-43, which may be the main proteinopathy over age 90. So the ATN definition will probably expand over the years to include these other factors. Rapid progress in blood biomarkers, expect that even in your country, within a year, there will be probably studies to validate their usefulness in screening people from primary care clinic to more specialized settings. And I mentioned the discrepancy between amyloid normalization and the small clinical effect size. So population-based prevention, this is a fun part. You will enjoy that. This is the list updated in 2020 by the Lancet Commission about the known risk factors. So there's a lot of them. I'll let you look. Hearing loss was a surprise. It's indeed a powerful factor at play in dementia. And so much so that in clinical practice or geriatric practice, we should really systematically look for and treat hearing loss as a risk factor for cognitive decline. Air pollution was a surprise, very important in industrialized countries, perhaps soon around the world. On the right, the red box, look at factors that are still under study, but I would expect them to be added to the big list of 12 eventually. Sleep disturbances. So during REM sleep, apparently you clear the beta amyloid out of your brain, and people who had difficulty sleeping chronically, they may be more at risk of cognitive decline. And the other hot topic is impaired oral health. So chronic gingivitis, these bacteria, some of them may get into your brain and stir up chronic neuroinflammation. So that's another practical thing. If you care for people that are older, you have to make sure they brush their teeth, that perhaps they use mouthwash, etc. It's an important factor. So now I will take you through briefly to two recent publications that are more specific about risk and protective factors and that may be relevant to your practice. So this one is from the Framingham study, so it's US-based. They looked at three vascular oriented risk factors: diabetes mellitus, physical inactivity, and obesity. And no surprise, the hazard ratio is high, 1.6 times control, 1.57, and obesity, 1.76. So for a North American population, these are three risk factors. And if you have all three, your risk of dementia is much higher. So obviously, in terms of population-based approach, you should get everybody active physically and lose weight. And if you have diabetes, you treat it aggressively. That's also applicable to individuals if they have those risk factors. Now, a study from China, mainland, that was just published in the British Medical Journal 2 weeks ago. It's a big study, over 10 years, close to 30,000 Chinese, both in rural and urban regions, were monitored for cognitive decline. And it was found that there's a less memory decline over 10 years if you have a healthy diet, a regular physical exercise, active social contact, no smoking, no alcohol. And what's missing on the slide, I'm sorry for that, is active cognitive activities. So that could be reading, but preferably reading with other people, like a book club. Regular physical exercise is not really push-ups. It's really getting out regularly 3 times a week. No alcohol was a bit harsh, but there you go. It's actually happening in Canada. There's been a formal campaign to lower the alcohol consumption. And the protective effect is also seen in APOE4 carriers. So that's the good news. Even if you have inherited from one side of the family the APOE4 genotype, and you're more at risk of dementia, these healthy lifestyles work. So on the left, you see the decline over 10 years. The red are people who have no healthy habits, and the green is those who have 4 or more, and blue in between. And the point being made is that the bottom diagram is people who are APOE4, so they're more at risk. They also have a protective effect against age-related memory decline if you have healthy habits. Now, these are observations, epidemiologic type observations. Now, can you reduce risk progressively in a randomized clinical trial? So the prototype is FINGER. It was done in Finland, and this is a classic. So you have people randomized to regular health care and a package, a combination of nutrition, exercise, cognitive training, social activities, and very important vascular risk monitoring. So of course, those who get the full package do better than the control group, but the improvement was not so much memory, it was more executive function and processing speed. So this may translate into more autonomy for instrumental activities of daily living. And further follow-up beyond the 2 years of the study show on the right additional benefit, especially cardiovascular events. And if you look at the specifics, this was information provided to me by Dr. Mia Kivipelto, the lead investigator. So if you start this program and you already are at risk because you have had a stroke, a TIA, or coronary event before, so you have vascular risk factors to start with, having the full package will lower the risk of cognitive decline by 50%. So this multi-domain approach may be even more useful for people who already have risks to start with. So to summarize, population-based prevention is currently the most realistic way to decrease dementia prevalence, especially prevention of stroke. In addition, a personalized approach based on genetic and biological risk may be possible, such as if you have vascular risk factors. So Alzheimer's may become a chronic illness such as diabetes, where you have a symptomatic phase or mildly symptomatic phase and a late the organ failure phase. So to finish with something uplifting, can you develop clinical practice guidelines? Yes. We started in a way with the World Alzheimer Reports 2021-2022. And I just want to emphasize the important contribution of Taiwan for the World Alzheimer Reports. You see here the numbers of clinicians and patients and professional caregivers, and family caregivers who answered the survey. You're the country who answered the most based on population. So thank you. And just some highlights of the 2021 report. Healthcare systems must have culturally appropriate instruments. So I mentioned the NBIC, but all instruments use CDR sum of boxes, for instance, you should pay attention to because it may be part of the normal follow-up, the regular follow-up of people on anti-amyloid therapy. And then how to disclose the results to individuals, especially if we start having blood tests that say you may have amyloid and tau in your brain and you're like 50, 60-year-old, what do we tell people? So we have to adapt to the need to disclose risk factors to individuals. And for the 2022, which is about management, I'll just highlight some chapters that are more of interest to clinicians, like how to achieve a good post-diagnostic support in primary care settings, a chapter on symptomatic drugs, on new disease-modifying drugs, and my favorite chapter is 19, special care needs for people with specific kinds of dementia, like PSP, Parkinson, Down syndrome, very young onset, etc. So the World Alzheimer Reports, you get them online on the Alzheimer's Disease International ADI website. Two examples of clinician-driven guidelines. One from Canada. It's been a tradition over 30 years to get together every 5 years or so. Last time we went a little crazy. We had all these topics for discussion. We reviewed the literature, and we wrote some recommendations, and then we voted on them. And those who achieve 80% or more approval, they get published. And for instance, non-cognitive markers of dementia include gait assessment. So normally, if you follow all the recommendations in the geriatric clinic, you would assess gait in a structured way as much as cognition, because it's an important component of the risk factors or early symptoms of dementia. We also discussed de-prescription of anti-dementia drugs. So there comes a point in the course of dementia where donepezil is no longer appropriate, and it will be the same for the new generation of drugs. When do you stop lecanemab-like drugs? Is it after you normalize amyloid brain level at 18 months, and then you wait, and if the patient is stable, you don't need to treat again? Time will tell. Another initiative is from the US. Jeff Cummings led a working group to put together all information available about aducanumab, because it was approved by the FDA. So clinicians theoretically would have to use it for selected patients. So this is an investigator and clinician-driven initiative, and they update the guidelines for clinical practice use of the new generation. So this is something I would encourage you to do in your country for diagnostic tests and new therapies. Because the scope of what we do for dementia is now expanding, as you see here. Before dementia, there's the protective factors that I emphasize, and then anti-amyloid therapies. Maybe it will be appropriate for a few patients, for maybe a course of treatment of a year, year and a half. And then we still have the antidepressants, cholinesterase inhibitors, memantine, and all the other non-pharmacologic approaches that we have. So to conclude, care for persons living with dementia and their carers need to be appropriate for each stage of disease, and that's maybe very early, MCI, MBI, and then mild, moderate, severe. And ideally, it's the same clinical team, but it's not always possible. And ideally, an anchor person, like a nurse, someone you can call, like we do for oncology or chronic illnesses such as diabetes. Biomarkers, particularly in the blood, may offer a personalized approach for diagnosis, but careful what you wish for. You'll have a blood test, it's abnormal, p-tau is very high. Okay, what do I do with that information? A combination of protective factors may
Thank you for your attention. And we ran out of time using the Zoom 40 minutes. So the last slide was cut short. So a combination of protective factors may delay onset of symptoms and at the population level. And clinicians such as you have an opportunity to update their best practice guidelines based on evidence. Thank you. I look forward to your questions.
Okay, thank you, Professor Gauthier. Any question from our audience, also from our YouTube audience outside this meeting room? Yes, maybe I can ask the first question. You mentioned the natural cause of Alzheimer's disease, mild behavioral impairment, MCI, may could be the symptom before the cognitive function impairment. How can we detect the MCI in our OPD, or how to educate the family to catch the symptom of MCI in the family?
Actually, the secret is to carefully to what people say. You will have families where they will pretend there's nothing wrong, and they will deny there is an issue. Other people, they they say there's something wrong, and when you test them with the MoCA or more structured neuropsychologic assessments, you find nothing wrong, but they know subjectively there is a change compared to how well they performed before. So you see a bit of everything as clinicians. And in between, you have people who are, let's say, over age 70, who have, mostly the family will report there is a change in some abilities. It could be just hobbies, just remembering what cards were played in a bridge game, or just being late to pay a bill, or not taking their pills on time. So that's the first cue that you should probe. You may need a separate visit if you're a family practitioner. Or if you're a specialist, then you may want to use a more structured checklist. The IQ code, for instance, it can be filled by the family. It looks at all the various activities of daily living. Or you can use semi-structured questionnaire about daily life for that person, as I used to do when I was in medical practice. So my short answer to your important question is listen carefully what people have as a complaint, and then probe into the impact on their daily life, and then decide if you want to just do a MoCA screen, or if you want to do a more structured VASCOG, or a full neuropsychologic assessment. So that's my short answer.
Thank you so much. Is there any questions? Dr. Wei Li, I saw you have a study on the MCI. Sorry, MBI. Okay.
Oh, yes.
Please.
So thank you, Dr. Gauthier. I'm Dr. Li from Taichung. I have a question about, do you see any difference, especially based on the biomarker difference between the MCI and MBI group due to Alzheimer's disease? Because I think the initial symptoms of the Alzheimer's disease vary in different individuals. So do you see any biological difference between the two groups? Thank you.
A very good question, because we are indeed finding, using PET imaging, some amyloid deposition and early tau spreading in some people with MBI-related symptoms. But it's early days, and we don't want to start worrying everyone over age 50 who gets a little cranky at times or a little depressed at time. It may be due to a lot of things, ranging from your mother-in-law moved in to you don't like your boss. So, but if you are doing a research cohort, yes, by all means, try to find biomarker correlations with symptoms, and with the help of the lead investigator about MBI, Dr. Zaina Ismail, we can help refine your analysis and maybe compare your cohort with that of McGill and others around the world, and then we can publish together something very meaningful. Okay. So I'm happy that you're interested in the neuropsychiatric presentation of AD, and it's not very specific, but it may lead to the use of appropriate biomarkers, especially in the blood, and then maybe specific PET scan or spinal fluid examination. It may lead to an earlier diagnosis of AD, for instance, and then maybe we can treat even earlier than MCI.
Yeah, thank you.
Yeah. Okay, regarding the treatment outcome measurement, I usually ask my patient and family, what is the meaningful improvement of the treatment? And maybe I told them your CDR sum box decline is slowly, but they don't believe me. They say, oh, my patients got worsened. So what do you think? What is the tool to measure the so-called meaningful outcome?
That's an excellent comment you make. We have a geriatrician in Eastern Canada, Dr. Ken Rockwood, who also feel like you that you should ask the family and the person with or symptoms, what's important for you now at this time in your life? What would you like to maintain for the next year that you would consider it important for you? So I think he called it goal attainment scaling. So you can look it up in the literature. Goal attainment, A scaling, SGAS. And essentially it's asking people, even when you start donepezil or Exelon patch or galantamine, and now the new drugs coming, before you start, what would you like, name 3 things that you would like to maintain that are important for you. And then when you do your follow-up at 6 months, 12 months, you ask about those 3 items. And if you have 2 out of 3 that are stable, whatever score you get on the MMSE and the CDR sum of boxes, it will be meaningful.
Okay, thank you. Yongxuan, please. Yongxuan, can you ask your question by yourself?
Okay. Hello, can you hear me?
Yes, please.
Okay, thank you, Dr. Gauthier, for your informative talk. I would like to ask that from the figure of panels with amyloid, tau, and FDG PET, some patients seem to have more tau deposition than amyloid, or even they start with tau deposition. What is your opinion of this phenomenon?
You're quite right that maybe 10% of people, we say clinically they have Alzheimer, there's no amyloid or very little, and it's predominantly tau. And of course, these people should not go on anti-amyloid therapies. They should be randomized into anti-tau therapies, which there are not many right now, unfortunately. But this is a first step in precision medicine for us. We will be able, within 3 to 5 years, to channel people with very early symptoms into an amyloid predominant course or tau predominant course, or neuroinflammation predominant, or maybe some other protein like TDP46, and then we can 43 rather, and then we can select the best kind of treatment based on the biologic profile. We're getting there. It's a bit like chemotherapy. We're about 30 years behind oncology, but we're catching up quickly.
Thank you.
Okay.
Yeah. I have another question. I'm Dr. Lee.
Yeah. Please.
Yeah. Dr. Serge, you mentioned about the combined therapy for maybe early Alzheimer's disease. And so which kind of so-called combined therapy you expect will be available in the future soon? Is there any hope for us?
Yes, absolutely. I mentioned the sequence. It's just being practical. We don't have drugs approved right now for amyloid and tau, so we cannot combine them together in a factorial design, which would be the ideal one. So you get drug 1 plus placebo, drug 2 plus placebo, placebo, the 2 drugs together. That won't be done with these kinds of drugs in the foreseeable future. It was tried for memantine with donepezil, and the results were equivocal, the domino study, so-called. So just an example of combination therapy. If you have donepezil and then you're randomized to donepezil alone, placebo, memantine alone, and the 2 drugs together, everybody except the placebo is better off at the end of a year. But there's no difference if you're on 2 drugs together or either drug. So this hopefully will be better designed for the new generation of disease-modifying drugs. So as I mentioned briefly, once you've had your course of amyloid therapy, if you did have amyloid in your brain to start with, you're in remission. So maybe that year that we know there is stability of low amyloid levels without therapy, you can take that year as an opportunity to randomize to another treatment. So anti-tau or placebo, or compare 2 anti-tau therapies in people who have now normalized their amyloid. Now, if you have no amyloid to start with, as the other young doctor was mentioning, yeah, you shouldn't be on anti-amyloid therapy to start with. So you should go on anti-tau or anti-inflammatory drugs. So 3 to 3 years, maybe if we're lucky, maybe 3 to 5 is more realistic in terms of evidence base to select the drug to start with, most important, and the second drug to add once you show that there is a bit of worsening. The worsening may be just biologic. p-tau 217 is coming up again, like PSA for prostate cancer, or it's clinical. There's a significant clinical worsening to be determined how we measure that, and then you start your second course of treatment, which may be anti-amyloid therapy again, or some other treatment. This 3 to 5 year horizon, you're going to see this. You're young enough.
Thank you.
Okay. Dr. Huang Likai, do you have any question?
Yes, do you hear me?
Yes.
Thanks for Professor Gauthier, especially for your patience and kindness during our technical problem. Thank you. I'm wondering, because you have mentioned that some healthy, like cognitive normal population, they may have very prominent pathology in their brain. Do you think that we should do treatment before or early whenever we find amyloid accumulation, especially prominent state preclinical? And the second question I'm wondering, because some previous trial have not shown so obvious clinical improvement or delay of decline in cognition. What will you comment on the different like monoclonal antibody therapy? Thank you.
Yeah, thank you for your questions. The first one, of course, somebody who's 90 with amyloid in their brain, no symptoms, they don't need anti-amyloid therapy. They just need excellent general care for comorbidities, including hearing impairment and good nutrition and lack of isolation. So what we're talking about here is someone in their 60s who would be found to be amyloid positive. We'll have an answer within 2 years with the A4 study underway in the US. Dr. Sperling believes strongly that treating amyloid early will indeed have a lasting impact. But this needs to be demonstrated. So I would say that it's going to be age related. And perhaps other factors at play. If you're ApoE4 plus, you have amyloid in your brain, it's a more aggressive course of therapy perhaps you should envisage, because that person is more likely to progress. You have a double risk. You have a biological risk, you have amyloid high levels, plus you have a genetic risk. So we may end up with an algorithm to determine who needs, let's call it usual preventive care, and someone who needs more pharmacologic care, which would include anti-amyloid therapies. By the way, you're aware there's an oral anti-amyloid therapy being tested. It's not going to be IV every month. In 3 years, we'll have oral agents. So it's going to make it easier to manage people long-term who needs chronic anti-amyloid therapies. Your second question was why don't we see similar effects with different monoclonal antibodies? If they normalize the amyloid levels, we should have an equal effect on clinical benefit. There may be a subtle difference in how the antibody works in a certain fragment of the beta 42 molecule. Even with lecanemab, the effect is not big. So maybe this sequence of combination therapy we already discussed should become tested quickly. In other words, if you treat only one component of disease with 3 major components, tau, amyloid and inflammation, we need to treat 2 at least out of the 3 to have a meaningful clinical effect. So my prediction is that there will be now a rush to have an amplification of the anti-amyloid therapies by combining with agents acting on another component of the disease.
Thank you, Professor.
Yes.
I hope you realize how exciting times we live in our field of dementia. And I can just imagine what it will be like your practice in 5 years when you have biological tests in the blood to select people who needs a lumbar puncture or a PET scan, and then you'll be able to choose the class of drug, the first line of treatment based on their biologic profile. Hey, who would have thought that 5 or 10 years ago? So try to bring in young people in the field, get them excited about the field, so we have enough people to give the treatments and see all the patients who worry.
Okay. You mentioned the loneliness is the potential risk factor for dementia. Do you see in any impact of pandemics in your patients, especially in Canada?
Yes, thank you for bringing this up. Indeed, social isolation was a cruel component of the COVID pandemic, and so many people with dementia died alone, away from their family, because families were not allowed, because of COVID risk, to be with them in their last days. Even people at home, even with living with one person, they were isolated from their usual social networks because of the COVID. So there's still work to be done on measuring what happened. There's another thing that happened is we have a delay of diagnosis now. I don't know if it's the case in Taiwan, but there's probably a 2-year lag now in catching up with diagnosis of people with symptoms. And the final thing is long COVID. It's a new wild card. Does chronic COVID or long COVID act as a fourth factor in the progression towards dementia? If you have already amyloid tau neuroinflammation, is long COVID a fourth factor that will increase the number of people with dementia in one generation, which would be terrible, because we were hoping to have less people with dementia if we use all the vascular protective factors and healthy lifestyle strategies, which were starting to work, at least in some parts of the world.
Thank you. Thank you. I think it's very important issues. Okay. Because we have run out of our time, and I think it's a very late night in Canada. We thank Professor Gauthier again for his wonderful talk and the meaningful communication with us. Thank you. Thank you.
Pleasure and an honor.
Thank you.
Bye-bye.
Bye-bye. Bye-bye.